Have you ever found yourself wondering about the unseen battles constantly happening inside us, especially, in our lungs?
It's a pretty intense thought, isn't it?
Yeah. Today, we're going to sort of pull back the curtain, maybe play medical detective a bit, uncover the hidden lives of some tenacious microscopic invaders and the clever ways our bodies and doctors fight back. We're taking a deep dive into a whole collection of medical sources, notes, research, really trying to give you the essential insights into a range of significant respiratory infections.
Mhm.
We'll cover everything from, the surprisingly resurgent whooping cough to various types of pneumonia, even some tricky fungal ones. Our mission: cut through the noise, give you a shortcut to being well-informed, maybe with some surprising facts, maybe a bit of humor, too. Keep you hooked.
Well, what stands out to me as we get started on this deep dive is just how vital it is for all of us to grasp these concepts.
Right.
Understanding these conditions, from those subtle early symptoms right through to the diagnostic nuances and how we prevent them, it really empowers you.
Mm-hmm.
You can make more informed decisions about your own health, contribute more effectively to public health discussions. This knowledge isn't just for doctors, it's for everyone.
So let's unpack this fascinating world, these respiratory invaders. Okay, let's start with a classic. A respiratory classic that many people might assume is kind of thing of the past: pertussis, whooping cough.
Yeah.
It's surprisingly tenacious, isn't it?
Absolutely. And what's truly striking here isn't just the epidemiology itself, but the surprising resurgence,
Yeah.
a disease many thought was largely conquered. Our sources highlight that a big chunk of cases, like 38% for infants under 6 months
Wow.
and 71% for kids under 5, are in the very young. So classic definitely doesn't mean gone.
Right.
Risk factors are pretty straightforward: exposure, pregnancy, and crucially, incomplete or lapsed vaccination. It spreads easily, respiratory droplets, and that little bacterium, Bordetella pertussis, it sets up shop in your respiratory tract,
Mm.
releases toxins. That's what leads to those distinctive symptoms, usually after about a 7 to 10 day incubation period.
Okay, here's where it gets really interesting for me. The clinical journey. It's not just one long cough, is it? It unfolds into like 3 very distinct acts.
That's exactly right. It starts with a catarrhal phase, lasts maybe 1 to 2 weeks. Think of it like a bad cold, really runny nose, sneezing, hacking cough, often worse at night, mild fever usually.
Okay. The warm-up act.
Exactly. But don't be fooled.
Hmm.
Then comes the notorious paroxysmal phase. That's the hallmark of pertussis. Can last 2 to 4 weeks.
Right.
This is where you get those severe, uncontrollable coughing fits, often followed by that high-pitched inspiratory whooping sound.
That's the sound everyone knows.
It is. And that whoop is actually your body struggling to grab a quick breath after a spasm, sucking air against a nearly closed airway.
Mm-hmm.
Often worse at night. Can be so intense they lead to vomiting, fainting, even pauses in breathing apnea.
Scary.
Yeah, and for adults, it's often just frustratingly long.
Right.
They call it the cough of 100 days.
Right.
Then finally, the convalescent phase. Starts around week 4,
Yeah.
the cough gradually fades, but it can stubbornly linger for up to 6 weeks, sometimes longer.
I can only imagine how frightening that whooping sound must be, especially, hearing it from a child.
Yeah.
What are the major dangers, particularly for the most vulnerable ones?
Oh, it's incredibly alarming,
Yeah.
especially for young infants. They face the highest risk for severe complications.
Like what?
Things like pneumonia, either from the Bordetella itself or a secondary bacterial infection getting in. Failure to thrive, meaning they struggle to gain weight.
Okay.
And tragically, in very young infants, death and apnea, that temporary stopping of breathing, are real dangers.
Wow.
These little ones often need hospitalization, and strict droplet precautions are absolutely crucial in hospitals to stop it spreading.
Given how distinct those symptoms can be, especially the whoop, how do doctors usually confirm a case? And what's the immediate approach to managing it?
Well, often the clinical picture, especially with that telltale whoop, is actually enough for doctors to start treatment right away. Empiric treatment, without waiting for lab results.
Makes sense, given the risks.
Exactly. If testing is needed, a throat swab for PCR is generally preferred because it's fast.
Okay.
And interestingly, one striking clue on a blood test of the CBC is often a dramatic increase in lymphocytes, a specific type of white blood cell. That's pretty unusual for many bacterial infections, so it really helps point towards pertussis.
Ah.
As for management, supportive care is key. Oxygen, if needed. Clearing airways, keeping hydrated. Cough suppressants, surprisingly, don't really work here.
Really?
Yeah. Critically, macrolide antibiotics like azithromycin are the drug of choice. And they're prescribed not just for the patient, but often for close contacts too,
Why is that?
because they shorten the period of contagiousness. They reduce the spread.
Got it. Prevention is clearly vital for this one then. What should listeners know about the vaccines?
Prevention is absolutely our best defense. The DTaP vaccine that covers diphtheria, tetanus, and acellular pertussis is given in a series of doses throughout childhood.
Right, the childhood shots?
Yeah. 2, 4, 6 months, then boosters at 15, 18 months, and again at 4 to 6 years. For adolescents and adults, there's the Tdap booster, usually between 11 and 18 years.
Okay.
And crucially, it's strongly advised for pregnant mothers and anyone who'll be in close contact with newborns.
Why pregnant mothers specifically?
Because babies are too young to be fully vaccinated themselves right at birth. So by vaccinating the mother and those around the baby, we create this protective bubble. It's called cocooning.
Cocooning. Makes sense. Okay, so we've seen how pertussis is this very targeted, specific assault, but what happens when the lungs face, well, an even more diverse array of attackers? Let's broaden our view now to the complex world of pneumonia. It's definitely not just one thing, right?
That's absolutely right. Not at all. And what's fascinating here is how doctors categorize pneumonia, primarily into typical and atypical,
Okay.
which gives us a quick roadmap really to potential organisms and treatment approaches. But first, there's also the definition based on where you get it.
Right.
Community-acquired pneumonia, CAP, that develops outside a hospital, versus hospital-acquired pneumonia, HAP, which develops during or after a hospital stay.
Got it. So typical versus atypical, what's the difference there?
Yeah, the differences are key diagnostic clues. So
Yeah.
typical pneumonia, often caused by bacteria like Streptococcus pneumonia. Think sudden high fever, productive cough, meaning you're coughing stuff up, and sharp chest pain that gets worse when you breathe.
Ow.
Yeah. And on the physical exam, doctors might hear signs of consolidation in the lungs, different breath sounds, maybe dullness when they tap on the chest.
Okay.
Atypical pneumonia, though, often presents more subtly. Maybe a low-grade fever, a persistent dry cough. And it can even have symptoms outside the lungs, like muscle aches or stomach issues.
So not just lung symptoms.
Exactly. And what's intriguing is that with atypical pneumonia, the lung exam itself can often sound surprisingly normal.
Wow.
So the key takeaway isn't just what bug is causing it, but understanding why symptoms like a dry cough versus a productive one are such critical clues for doctors. It guides them even before the tests come back.
That distinction really changes how you think about even a common cough, doesn't it? Okay, let's dive into some of the most common culprits. Who are the usual suspects in this respiratory rogues gallery?
Right. Well, for typical bacterial pneumonias, the undisputed champion of community-acquired pneumonia is Streptococcus pneumonia. Causes about 65% of cases.
The big one.
The big one. Its calling card, sudden onset of chills, high fever, and that productive cough with thick, rusty-colored sputum.
Rusty sputum, got it.
Next up, Haemophilus influenza. Second most common cause of CAP. More of a concern for the very young, the very old, or folks with underlying lung issues. Then there's Klebsiella pneumonia. You often see this in people with weakened immune systems, alcoholics, diabetics, severe COPD. This one can cause marked inflammation and necrosis, tissue death, sometimes leads to a very distinctive current jelly sputum.
Current jelly. Wow.
Yeah. And on X-ray, you might actually see cavitary lesions, like holes forming. And finally, Staphylococcus aureus, staph, frequently swoops in as a secondary infection after a virus, like the flu.
Post-flu pneumonia.
Exactly, or in hospital settings. It's kind of notorious for causing widespread bilateral lung infiltrates or even abscesses.
Okay, so those are the typicals. What about those atypical ones that act a little differently? The ones with more subtle symptoms sometimes.
Right. The most common cause of atypical pneumonia, often called walking pneumonia, is Mycoplasma pneumonia.
Walking pneumonia, I've heard of that.
Yeah, this bug tends to affect young, healthy people, school-age kids, college students. Often starts with a sore throat, then progresses to a persistent dry cough, frequently without those dramatic lung findings on exam. And what's really important to remember is that because Mycoplasma doesn't have a cell wall,
No cell wall.
standard beta-lactam antibiotics, the ones that target cell walls, like penicillin derivatives, completely ineffective.
Right. So you need different meds.
You do. We use macrolides, like azithromycin or doxycycline instead. Another fascinating atypical bacterium is Legionella pneumophila, Legionnaire's disease.
Yes. The one from water systems.
Exactly. What makes this one unique is its transmission. It doesn't spread person to person. It comes from contaminated water sources, air conditioning systems, cooling towers, hot tubs sometimes.
Okay.
Risk factors include being immunocompromised, being a smoker, or elderly. Patients often present with fever, chills, cough, shortness of breath. But what truly stands out are often prominent GI symptoms.
GI symptoms with pneumonia.
Yeah, especially watery diarrhea. And neurologic symptoms like confusion can also be a big clue.
Wow.
And a classic kind of counterintuitive finding on exam is relative bradycardia, a slow heart rate despite a high fever.
Huh.
It is. Diagnosis often relies on rapid PCR tests or finding the antigen in the urine, and it's managed with macrolides or fluoroquinolones.
Okay, interesting. There's also a specific type of pneumonia that's more about how the infection starts rather than just what bug causes it, right? Like inhaling something.
You're talking about aspiration pneumonia.
Exactly.
This happens when you accidentally inhale microbes from your mouth or stomach down into your lungs.
Okay.
Most commonly, it's due to anaerobic bacteria, the ones that live without oxygen. But in chronically ill patients, it can also involve gram-negative rods or even Staphylococcus aureus.
And what puts you at risk for that?
Anything that impairs your consciousness, like substance abuse, stroke, sedation, or causes prolonged vomiting.
Right, so stuff can go down the wrong pipe.
Precisely. And classically, it affects the right lower lobe of the lung. Just because of the angle of the bronchus, the airway anatomy kind of guides stuff down there.
Anatomy.
Yeah. It's often associated with really foul-smelling rotten egg sputum, and it can lead to lung abscesses or empyema, which is pus collecting around the lung.
Nasty.
Very interestingly, though, while we used to always add anaerobic antibiotic coverage for suspected aspiration, the 2019 guidelines actually now advise against routinely doing that, unless you actually see an abscess or empyema.
Oh, why the change?
Recent studies suggest maybe anaerobes don't play as major a role in every case as we once thought. So unless there's clear evidence, first-line antibiotics are typically things like ampicillin sulbactam or amoxicillin clavulanate.
Fascinating. Okay, so now that we understand the various types and their signature characteristics, how do doctors typically approach diagnosing and treating pneumonia? What's the battle plan?
Well, the initial diagnosis often involves looking at radiographic findings, like a chest x-ray, alongside the clinical picture.
Right.
Then the treatment plan for community-acquired pneumonia, CAP, is tailored. Depends on your overall health, any comorbidities, and whether you can be treated at home as an outpatient or need hospitalization. So for healthy adults under 65, without other significant health issues, oral amoxicillin is often the preferred first choice now. It's good against the most common bugs like strep pneumo. Macrolides like azithromycin or doxycycline are also options. If a doctor suspects an atypical bug might be involved, sometimes they'll combine amoxicillin with a macrolide or doxycycline. But remember, for mycoplasma, those beta-lactams like amoxicillin won't work alone.
Got it. What about people with other health problems?
Right. For outpatients who have underlying health conditions or other risk factors, the approach shifts slightly. Often involves combination therapy, maybe a beta-lactam/beta-lactamase inhibitor like Augmentin or a cephalosporin, PLU as a macrolide, or sometimes monotherapy with a respiratory fluoroquinolone, though combinations are often preferred if possible.
And if you're sick enough to be in the hospital?
Inpatient treatment. Typical combination therapy again, like a beta-lactam plus a macrolide, or monotherapy with a respiratory fluoroquinolone.
Okay. What about kids?
For children, between 6 months and 5 years, high-dose amoxicillin is usually the drug of choice. For kids 5 years or older, amoxicillin is still often the choice, but macrolides get considered more strongly if atypical CAP is suspected. It's all about picking the right weapon for the suspected enemy.
Absolutely. This raises an important question. What about prevention, especially through vaccination? How do we proactively fight back against pneumonia?
Yeah, pneumococcal vaccination is absolutely a cornerstone of prevention. We have two main types of vaccines.
Okay.
The pneumococcal conjugate vaccines, PCV13, PCV15, PCV20. These create a really strong immune response, even in young children. And then there's the pneumococcal polysaccharide vaccine, PPSV23, which covers a broader range of serotypes or strains of the bacteria.
Right. So different types for different purposes or ages?
Sort of. For children, a series of doses of a PCV vaccine is recommended in the first year or so of life, with a final booster around 12-15 months. That provides that strong foundational immunity. For adults, vaccination is indicated for everyone 65 and older. And also for those under 65 who have certain risk factors like chronic lung disease, heart disease, diabetes, weakened immune systems.
And what do adults get?
Well, the recommendations have evolved a bit. Now, you generally have a choice. Either a single dose of PCV20 that covers 20 serotypes,
Okay, one shot.
or a sequential regimen. You get PCV15 first, followed by PPSV23 about a year later. Or if you're immunocompromised, you can get the PPSV23 sooner, maybe 8 weeks later.
Why the two-shot option?
It combines the strong response of the conjugate vaccine with the broader coverage of the polysaccharide vaccine. So it's kind of like building layers of protection, ensuring broad and long-lasting immunity against this really common cause of serious pneumonia.
Makes sense, building that defense. Okay, now let's shift gears completely. Let's explore an often overlooked category of respiratory invaders, fungal infections. These really pose a unique diagnostic puzzle, don't they?
They absolutely do. Fungal infections can be quite tricky, making diagnosis a real detective challenge sometimes. Let's start with histoplasmosis.
Histo. Okay.
This infection comes from Histoplasma capsulatum. It's a dimorphic yeast.
Dimorphic. What's that mean?
Dimorphic means it's pretty clever. It can grow in two different forms, like a mold out in the environment, in the soil,
Okay.
and then as a yeast form inside your body at body temperature, which helps it infect us.
Ah, sneaky. Where do you find it?
It's commonly found in soil, especially soil enriched by bird or bat droppings,
Bird or bat droppings, right?
which is why it's so prevalent in certain areas like the Midwestern U.S., particularly the Mississippi and Ohio river valleys.
The histobelt.
Exactly.
Right.
Activities that stir up that soil farming, demolition, construction, even exploring caves, spelunking, can expose you.
Okay. So who gets sick from it?
Well, actually, many people who get exposed to histoplasma never get significantly sick. Their immune system handles it. But the primary risk factors for developing symptoms, especially severe disease, are weakened immune systems.
Like HIV.
Particularly individuals with severely low CD4 counts, like in uncontrolled HIV, yes. Also, infants and young children are more affected because their cellular immunity, a specific part of the immune system, is still developing.
I see. And what does it look like clinically?
Most often, people might just have asymptomatic lung involvement, or it can mimic a cold, the flu, or even atypical pneumonia, fairly nonspecific sometimes. But in immunocompromised individuals, it can spread or disseminate throughout the body. That can cause fever, weight loss, an enlarged liver and spleen, sometimes even mucocutaneous lesions like sores in the mouth.
Wow. So it can go way beyond the lungs.
It can. Diagnosis can be tricky. It often involves antigen tests, looking for parts of the fungus in urine or sputum. PCR tests are also very specific. Antibody tests can be helpful too.
Okay.
Cultures are the most specific test, but they can take weeks to grow. Sometimes biopsies are needed, looking for the yeast forms under the microscope with special stains.
And treatment.
Asymptomatic cases usually don't need treatment. For mild to moderate disease, the antifungal itraconazole is typically used. For severe disease, especially disseminated disease, we use more potent drugs like amphotericin B.
Amphoterrible. I've heard it called that due to side effects.
Yeah, traditionally it had significant side effects, especially kidney toxicity.
Yeah.
But now we often use lipid formulations, which are much better tolerated.
Good to know. Okay. And then there's pneumocystis pneumonia, or PCP. That's another significant one, right? Especially in certain patient groups. What makes PCP so distinct?
PCP. What's truly fascinating here is how unique PCP is, even among fungal infections. It's caused by Pneumocystis jirovecii. Now, technically, it is a yeast-like fungus.
What?
But crucially, it doesn't respond to typical antifungal medications like the ones we use for histo.
Really? Why not?
It just has a different biology, different targets. This makes its management very specific. It's actually the most common opportunistic infection in immunocompromised patients,
Who's most at risk?
particularly those with very low CD4 T cell counts, especially below 200, as seen in advanced HIV/AIDS. But also people on chronic steroids, undergoing chemotherapy, or organ transplant recipients, anyone with a significantly weakened immune system.
Got it. And clinically, what does PCP look like?
Well, the classic triad of symptoms includes progressive shortness of breath, especially with exertion. That's often the most common complaint,
Okay.
along with fever and a persistent non-productive cough. Dry cough, usually.
Dry cough again? Like
Yeah.
some atypicals.
Yes, and hypoxemia, low blood oxygen levels, either at rest or when they exert themselves, is a highly suggestive finding. Very characteristic.
Okay. How is it diagnosed then?
For diagnosis, nearly all patients will have at least two of those main symptoms, often along with important lab markers, like an elevated LDH level, that's lactate dehydrogenase.
Albedo.
Induced sputum, where they try to get the patient to cough up deep lung secretions, is often the first diagnostic step. But if that's negative or can't be obtained,
To know.
then doctors will typically perform a bronchoscopy, go down with a scope, and wash out a small part of the lung that's called bronchoalveolar lavage, or BAL, to get a sample to look for the organism.
Right. What about chest X-ray?
Chest radiographs often showed diffuse bilateral interstitial infiltrates, sort of hazy appearance throughout both lungs. But, and this is important, a normal X-ray doesn't rule out PCP. Up to a third of cases can have a normal or near normal chest X-ray initially.
Good to know. Doesn't respond to antifungals.
So what is the treatment?
The drug of choice for PCP is trimethoprim sulfamethoxazole, often called TMP-SMX or Bactrim,
Bactrim, okay.
given for 21 days. And interestingly, this is also the same drug used for prophylaxis, meaning preventing PCP in people who are at high risk.
So treatment and prevention with the same drug.
Exactly. Now, a critical insight, especially for managing severe PCP in hypoxic HIV-positive patients, is the use of adjunctive corticosteroids. Steroids. Why? Isn't that suppressing the immune system more?
It seems counterintuitive, right?
Yeah.
But it's crucial here. It actually helps reduce mortality and prevent respiratory failure. The thought is that when the antibiotics start killing the fungus, there's a big inflammatory response in the lungs that can actually make the patient worse initially. The steroids help temper that inflammatory response.
Okay, that makes sense.
Yeah, it's a really important part of the treatment for severe cases. And of course, for people with sulfur allergies, there are alternative treatments, but they often come with their own considerations, like needing to check for G6PD deficiency before using certain ones.
Wow. Okay, we've covered a tremendous amount of ground today. I mean, from the distinctive phased attack of whooping cough
Yeah.
to the subtle but critical differences between typical and atypical pneumonias, and even these surprising environmental factors behind fungal infections like histo. It really paints a vivid picture, doesn't it? The diverse ways these invaders interact with our bodies.
It really does.
Yeah.
And if we connect this to the bigger picture, it just highlights the incredible complexity and diversity of respiratory threats. It's not just about one or two bugs, is it?
No.
It's an entire ecosystem of invaders, each with its own signature move, its own strategy. Understanding their epidemiology, their unique clinical presentations, and, crucially, their very specific management strategies.
It isn't just academic. It's essential for protecting ourselves and our communities.
Absolutely. This deep dive, it wasn't just about, memorizing facts from the sources. It really felt like connecting the dots, seeing those aha moments in how these different invaders challenge our bodies and how medical science has developed such targeted, often really ingenious ways to fight back.
Which I think raises an important question for you, for the listener. How does this kind of in-depth understanding of these specific respiratory conditions maybe change your perspective on the broader landscape of infectious diseases? Or maybe on public health initiatives like vaccination programs? Something to think about. Definitely something to think about. Keep those questions coming, keep exploring, and we'll catch you on the next deep dive.